Here is your question.
Yes, ma'am, I'm ready.
All right. So if you have read and understood, considering it critical care scenario, please tell me, how are you going to manage this patient now?
I will manage this patient according to the Ccrisp protocol.
Yes.
I will give normal saline to the patient along with potassium, and uh, I would monitor the serum electrolyte, fluid balance, or the resuscitation success signs through urine output, blood pressure, and pulse.
Okay.
And I will do investigations like ultrasound abdomen and ultrasound X-ray abdomen and chest.
All right. Okay. Now that you have looked at the labs, patient labs in front of you, what would be your provisional diagnosis? What is this patient suffering from?
Yes, looking at serum electrolyte and pH, this
Mhm.
patient has hypochloremic metabolic alkalosis.
Okay. So what is the pathophysiology behind this situation?
Uh, Behind the pathophysiology is because of the vomiting. Patient expels sodium and chloride from the gastric contents through vomiters,
Okay.
and because of that, patient has hypochloremia. And due to hypovolemia, patient has renin-angiotensin system activation that causes aldosterone secretion, absorption of sodium and water, and excretion of potassium. And in this way, patient develops hypochloremic metabolic alkalosis along with hyponatremia and hypokalemia.
Okay, please tell me what might be the underlying causes of which have contributed to this condition of the patient, because it does
Uh,
not happen normally in normal human beings.
yeah, because of the peptic ulcer disease, there
Okay.
is hypertrophy or edema of the pylorus causing hypertrophic pyloric stenosis, obstruction.
Are you sure there is hypertrophy?
Yes, ma'am.
Because of edema, and there is ulceration. Ulceration leads to scarring and fibrosis.
Yes.
Right. But there is no hypertrophy. Hypertrophy of what? Gastric muscles? So hypertrophy is the wrong. All right. Okay. Because of that, what has happened? That has led to obstruction of
Uh,
the gastric outlet.
yes.
Yes. And
And
then,
that has caused metabolic abnormality and
okay.
dehydration in the patient.
There is one
Uh,
situation. What else could there be? Because I asked you if there, what might be the underlying causes. Gastric outlet obstruction could be one. There could be,
okay, malignancy. Yes,
yes,
gastric and
yes,
pancreatic
very good.
malignancy can also cause the gastric outlet.
Yes, and there could
Yeah.
even be tuberculosis. There could be pseudocyst of the head of the pancreas, which is, or the, yeah, which is causing obstruction. All right.
Oh,
Okay. Please tell me what might be the causes. If you could tell me the major or the etiology behind the gastric outlet obstruction.
most common is the peptic ulcer disease,
Ulcer disease. Yes, very good.
and second most is gastric malignancy,
Yes.
and
So,
third and
yes.
fourth, as you said, pseudocyst of the pancreas
Yes.
or TB.
Yes. And even gallstone obstruction could even lead to that. All right. Right. You have told me. Okay. How are you going to take care of patient's potassium levels?
I will give with normal saline. I will also give potassium to the patient in the
Yes. How
fluid.
much?
I would, there's a formula for that. For potassium, I would calculate the deficit according to the serum potassium, and also give the maintenance of daily requirement. So it would be the deficit along with the daily requirement of the potassium that I will give in the fluid.
Do you think this lady is fit to be operated right now?
Uh, I don't think so. She
All right.
needs to be shifted to the, after resuscitation, shifted to the critical care.
Yes.
And after that, proper investigations need to be done. If endoscopic dilatation can be done,
Yes.
that would be the most minimal invasive. Otherwise, we can go for a gastrojejunostomy.
Okay, good. Please tell me, how would you how much should be the normal potassium level?
It is 3.5, 4.5.
Okay, how would you comment on the potassium level of the patient right now?
It is 1.9. It's too low.
Sorry, sodium, I had to ask you. Sodium level.
Sodium is also quite low.
Yes.
It is
So
125.
what are the complications of hyponatremia?
It mainly affects the CNS system. Patient can have agitation,
Yes.
confusion, fit, or low
Yes.
GCS,
Yes. Okay, and can even lead to cardiopulmonary arrest and
renal
coma and
failure.
death. Okay, please tell me, how would you classify different levels of hyponatremias, and kindly give examples as well.
Yes, there are hypertonic hyponatremia, isotonic hyponatremia, and hypotonic.
Give
Uh,
examples of each, please.
Okay, hypertonic is due to the hyperglycemia, mannitol or glycerol infusion, and hypertonic are due to the hyperproteinemia or hyperlipidemia. Then there are, isotonic are due to hyperproteinemia and hyperlipidemia. Then there are hypotonic hyponatremia, which are divided into euvolemic, hypovolemic, and hypervolemic hyponatremia. Uh, hyponatremia would be divided below serum urine sodium. If it is less than 10, then it could be due to dehydration, vomiting, or diarrhea. But if urinary sodium is more than 20 and patient is hypovolemic, then it could be due to other causes like diuretics, cerebral salt wasting, or mineralocorticoid
Good.
deficiency. Then euvolemic causes, there is SIADH, adrenocorticoid deficiency, and in hypervolemic the causes are hepatic insufficiency, renal insufficiency, nephrotic syndrome.
Okay, please, last question. Please tell me, when a patient presents with vomiting and results in metabolic alkalosis, why would there be increased bicarbonate levels?
Because the pancreatic juices which are needed to neutralize the acidic content which comes in the duodenum, that is not needed as there is no acid in the duodenum. And
Okay.
there is also activation of renin-angiotensin system that causes the reabsorption of sodium and water and excretion of potassium with hydrogen. And to neutralize that acidic urine, in exchange of H ion, the
Hydrogen. Yes,
bicarbonate is reabsorbed.
very good.
Renal
Good.
tubule.
Perfect. Thank you so much.
Thank you.